Hi, everybody. We are here with our new guest at the NOVATALK, that is Nicholas Rolnick, main expert of BFR. And he is a physiotherapist, a colleague from the US. He has achieved his DPT at the Columbia University with academic honors, and he is a certified strength and conditioning specialist as well, and the co-founder of BFR Pros. Nick, can you tell us something more about that?
Yeah, no, just first and foremost, thank you, NOVAVIA, for having me. I really appreciate the platform to be able to talk about blood flow restriction and to try to get the word out because I truly believe that BFR is a useful therapy that we can as physical therapists integrate into our clinical practice to help accelerate our patients' performance and recovery. So first and foremost, just wanted to say thank you to that. And finishing off on my bio, it's really important for myself as well as the BFR pros to be an unbiased source of education. And what that means is that we don't have any role in selling equipment. Our goal as the BFR pros is to make sure that evidence-based blood flow restriction reaches the masses, and it reaches the masses in as safe of a way as possible. So I take my role as an educator very seriously because it's really important for me that this therapy continues to grow because it can influence and really change so many people's lives. So on top of just talking about blood flow restriction and giving workshops and speaking about it at conferences, I'm also an active, or I'm going to be publishing research on blood flow restriction. So I'm starting this summer investigating a relatively important question in the BFR literature. So a little bit more information about that will be forthcoming. Hopefully that happens with the COVID crisis. But other than that, I have my first published research paper accepted. This was actually on bodybuilding, mind you, but the applications for blood flow restriction in the bodybuilder. So I'm really trying to push the field of blood flow restriction forward. And I take that responsibility very seriously, and I want to make sure that people are implementing it safely in their clinical practice. So that's a little bit about who I am as a person.
That's fantastic. Congrats, by the way, for the first paper accepted regarding BFR. Well, Nick, for those who are really curious to know more regarding BFR or to know how everything started, can you tell us something more regarding the history of BFR and when and where it started, and how it became a tool on the toolbox of the physiotherapist, and how it is coming inside our PT scope of practice?
Yeah, so I think the first thing that we need to understand is exactly what is blood flow restriction, because blood flow restriction, once we understand what it is and then how it operates, we can then understand how it can best impact the lives of our patients. And so blood flow restriction involves the use of a cuff that's calibrated by some sort of technology, whether that's with a computer-operated device or something like an external Doppler. So something whereby we can understand the amount of pressure that we're applying to that individual. Now that cuff can be a variety of different types. It can be as small as about 5 centimeters wide up into about 17 or 18 centimeters wide, and that's put on the proximal most part of the arm or the leg. And because of that, what happens is we are partially restricting arterial flow to the limb and fully restricting venous return. And in doing so, this alters the local metabolic environment that surrounds the muscle that is distal to the cuff. And that's important because what happens is we have an accelerated form of fatigue such that we can fatigue our muscles at an accelerated rate compared to lifting the same amount of weight but without blood flow restriction. So we can reduce the time needed in order to get a training effect. And for us as the BFR pros, we actually don't stand for BFR as in blood flow restriction. We actually stand for better for results. So we adopt technology and promote technology that truly is better for results. And the research that has been coming out on BFR, along with tons of amazing anecdotal stories, are now supporting the use of BFR in clinical practice in patients and individuals of all different demographics. And so that it basically means that you can then take a load in rehab whereby you're not able to lift heavy, right? Because traditionally speaking, we are thinking that you need to lift 60 to 70+% of your 1 repetition maximum in order to stimulate muscle hypertrophy and muscle strength. What the recent research now has shown is that we can use low loads, whether that's with blood flow restriction or not, but we can take those low loads as long as we work toward a significant amount of fatigue. We can then create similar adaptations in our muscle mass and, to a lesser extent, our strength. And that allows us as rehabilitation providers, as physical therapists, to be able to improve our patients' muscle mass and strength during periods of injury. So let's rewind this a little bit, because it's important to understand now that we have the basis of blood flow restriction. We can utilize this to not lift as heavy of a weight, but gain similar benefit, right? So let's actually rewind and figure out or learn where it actually happened or where it was invented. And it actually was invented in 1966 by a gentleman named Yoshiaki Sato, who, anybody who's listening who enjoys weightlifting and getting muscle, like bodybuilder, like me, I've competed in bodybuilding shows. I understand the hunt for improving your muscle size. And so Yoshiaki Sato, I think he was like 18 or so at the time, he was at, I think it was a church service, and he was bending down and he noticed that he started to get this burning sensation in his calves following the prolonged period of time sitting. And for whatever reason, he decided to tie a piece of elastic strap around his leg, and he started to exercise with it. And lo and behold, he started to replicate that burn, that feeling, that pump of the muscle that that you normally would get when you exercise with moderate to heavy loads. And so that was the birth of modern day Katsu training, and Katsu meaning added pressure. Now that started out in Japan, and that was in the 60s. Now fast forward 30, 40 years, and you're starting to see now that people are recognizing that partial restriction of blood flow to the extremities can help with fostering adaptation. So just because we are restricting blood flow, that's not necessarily a bad thing. Too much of a bad thing, or too much restriction for too long, is a bad thing, but so is chocolate. I love eating chocolate, but if I eat too much chocolate, I get fat. The same principle applies. It's moderation. And so what they're finding out is that hypoxia, or driving this restrictive stimulus, can facilitate some very beneficial adaptations despite the relatively low loads that you use during exercise training. So what happened is the military was starting to use it, and that started to show efficacy in preserving limbs and optimizing optimizing the hypertrophy of the limbs for people that were losing them during combat injuries, for example. Then professional sports teams started to get wind of the benefits. And then it kind of trickled down from professional sports teams to collegiate sports teams. And now it's even in high school sports teams. Well, now they're like, okay, well, this is working in healthy individuals. What about the injured populations? And that's where the rehab literature in the last 20 years has really started to pick up. And most recently, in 2019, Forbes magazine declared blood flow restriction as the hottest trend in fitness, but I'm going to add and rehab, because there is not a modality that we have in rehab that is more supported other than exercise and education for improving the well-being of our patients. And BFR literature is in its infancy, but what we can confidently say is that when you exercise with blood flow restriction, you can increase your muscle mass and strength relative to the same exercise performed without blood flow restriction. So the only thing I could say is if you're doing 3 sets of 10 repetitions for a bicep curl for 2 kilograms, for example, right? How many times could you do that before you actually get tired? Well, a lot. And blood flow restriction then allows you to reduce the time needed in order to get that to get a training effect. So it opens up a plethora of options for you as the clinician to help improve your muscle mass and strength when you're injured. And to answer that last part of the question, in 2018, the American Physical Therapy Association declared that blood flow restriction was within the scope of practice of physical therapists. So since then, it really has been catching on in the rehab realm. So it's again, and I talk about muscle mass, right? Muscle mass is great because it makes you look good, fine. But in reality, our muscle serves a very important function, and that is helping with systemic and local management of inflammation. It's also been linked to early morbidity or mortality and excessive morbidity, meaning your quality of life. And we know that muscle is a very active tissue. There is no other tissue that best exemplifies this fact than muscle. If you don't use it, you lose it. So when you're injured and you're not able to stimulate your muscle and be able to create this fatigue response that allows you to adapt positively, well, then you're going to experience significant muscle atrophy. And this can happen in a period of as early as 4 to 7 days. You can start to experience significant losses in your muscle size. Now, underneath all of that, there is something called anabolic resistance. What anabolic resistance means is that our bodies become more resistant to the beneficial effects of exercise and nutrition. And so what our job is as rehabilitation professionals is to put our patients in the most ideal and optimal opportunities to be successful. And blood flow restriction allows us to be able to put our patients in the best position to be able to stave off disuse atrophy, meaning atrophy that results from not doing anything because we're injured, and allows us to be able to get people back to the activities that they love quicker than the modalities that we're currently using right now. And there's unique properties of BFR that allow us to be able to do that. They include reduced joint stress for individuals that might have irritable joints, like those with osteoarthritis, those that might not be able to lift heavy because of a medical reason, for example, like a falls risk, or for those that have never lifted before that have osteopenia or osteoporosis. Blood flow restriction can be a suitable alternative. And for those individuals, that can't lift heavy for the time being, and then ultimately can lift heavy over time, blood flow restriction can serve as an excellent adjunct or bridge to be able to get them from unable to contract their muscle to full-blown sports performance. So blood flow restriction can be a tool that you can utilize throughout the continuum of rehabilitation. The key here is understanding why you're using blood flow restriction in the first place. Understanding the deficits that we as clinicians are working against during a period of injury, and how we can utilize our skills in exercise and exercise prescription to be able to get our patients back to the activities that they love as quickly as possible. Okay. So that's kind of where BFR fits in.
Okay, this is fantastic. So we are not talking just only of a trend that came out from bodybuilding, but a lot of literature behind it that is supporting BFR in rehab. But you mentioned previously that BFR could be used even in those patients that are suffering, for example, from OA, and we are talking about a range of patients that are more to a geriatric population. And this geriatric population, what about safety concerns? Because I may think about, high blood pressure or risk of deep vein thrombosis, since we are talking about BFR and, blood flow occlusion. So what about safety concerns on the utilize of BFR in a rehab?
Yeah, so that's a great question. And it's really important as blood flow restriction continues to grow that we pay very close attention to safety. Because generally speaking, right, what we're doing is we're applying a tourniquet to the limb. And in doing so now, we're restricting arterial flow and fully occluding venous return. So what are we doing here? We are creating a situation where we're stressing the arterial and the venous system. So when we talk about safety, right, we want to make sure that we're doing a couple of things. Number one, we're utilizing an appropriate medical screener, right? So we're looking at what conditions could be affected by the use of blood flow restriction. So we want to make sure that we have a waiver that we can give the patient, first and foremost, to be able to look over for him or herself prior to initiating the therapy, right? But then as providers, we want to make sure that we're aware of all the different ways in which blood flow restriction can interact with the musculoskeletal, cardiovascular, and hemodynamic systems. So you have to be aware of the physiology that goes on underneath. And lucky for us, right, anything that's kind of involving some sort of serious pathology to the arterial system, the venous system, and as well as a lot of the general contraindications in general, like cancer, for example, active cancer would be also contraindications with blood flow restriction. But mainly here, after you get past that, then the last step is utilizing proper equipment in terms of when you're applying the device itself. What measures can you utilize to minimize the safety risk, but continue to maximize the benefit to the patient? So it's a three-step process. So going back to step 2, really, which is the medical screen. What you want to make sure of as a clinician, number one, the biggest 2 things that people are concerned about when they bring up blood flow restriction. The first one you've already talked about, which is a deep vein thrombosis or a blood clot. And what that typically happens is due to the fact of excessive stagnation of the blood. So if we're occluding too much, for example, and we're not allowing blood flow into the extremity, well, then we're theoretically increasing the risk of a blood clot. Now, a lot of the times, the surgeons who aren't educated on what's going on with blood flow restriction, that is their main hesitation. But we have to also consider this. when individuals go into surgery in general, for the first 6 weeks, surgery itself is an independent risk factor for blood clots. The use of a tourniquet has not been shown to be a risk factor for development of blood clots. So that's number one. But with that being said, right, the additional risks of tourniquets involve excessively narrow cuffs. So narrow cuffs meaning that the width of the actual cuff is very narrow. Second, in order to restrict blood flow for a surgery, you're going to need to completely restrict arterial and venous flow. So you're going to be applying very high pressures to the skin. Third, the application time. When you are applying blood flow restriction in a surgical situation, for example, you're going to be applying it for 30, 40, 50, sometimes 60 minutes or beyond. So you're at a situation where you are using a narrow cuff, you are applying very high pressures, completely restricting blood flow, and you are now doing it for a very long period of time. Clinical-based blood flow restriction and how we're applying it in practice, we tend to use wider cuffs, which result in lesser pressures applied to the limb. And we do it for less time. So typically, I don't recommend inflating the cuff during BFR resistance training for longer than 2 consecutive exercises, meaning any more than 10 to 15, 20 minutes maximum, which would be a very high threshold. Typically, I would say over 90% of the people that I work with, I have them deflate or reduce the pressure after one exercise, which is about 8 to 10 minutes. So we're really taking those into consideration. Now, what does the literature say about safety and blood clots with BFR? Well, the literature actually, there was a couple of papers that have been recently published that have been looking at it, but generally speaking, what we have is that BFR does not increase the risk of blood clots. In fact, the application of BFR actually could produce anti-clotting effects similar to that of traditionally recommended 70+% of the 1 rep max. Now, how is that the case? Well, we think that because of the restrictive stimulus and we're creating a high oxygen debt locally in that environment, once we get the reperfusion of blood following the deflation of the cuff, this creates what we call shear stress. And this shear stress on the arteries signals to these cells that line the arteries called endothelial cells to release a lot of these these growth factors, such as TPA, tissue plasma antigen, which helps with breaking up clots, but it also releases other factors like nitric oxide and vascular endothelial growth factor. These are all factors that can help with improving collateral circulation, which is part of the reason why we see benefits with walking with BFR, for example. So in general, the blood clot argument for right now, if we apply BFR, if we can utilize sound clinical judgment, which involves an appropriate medical screen, but also being able to apply BFR using the appropriate equipment, and that means standardizing the pressure that we apply to the individual relative to that individual. So, for example, a lot of the earlier BFR research was using similar pressures. So if I am doing a bicep curl exercise, my arm would be experiencing the same amount of applied pressure as a woman's arm, for example, or your arm. And as such, the relative intensity of the exercise would change because my arm is of a different size than a woman's arm. And so in order to standardize and minimize the safety risk, we need to make sure we're standardizing the pressure relative to the individual. And that is done something called the limb occlusion pressure. So that's a way that we can minimize the safety risk associated with blood clots because we're never reducing or we're never completely abolishing blood flow to the extremity. We're always getting blood flow in, and we're not creating a situation like if we're using potentially what we call arbitrary pressure, which would be the same example I just gave you, that we're exercising under full occlusion. So that's the first big one. The second one is something called rhabdomyolysis. So rhabdomyolysis is excessive muscle damage. In fact, it's a medical emergency. And typically, we find rhabdomyolysis occurring when we start to do unaccustomed exercise of anything. BFR, regular exercise, it doesn't matter, right? It's not exclusive to BFR. But because BFR challenges the local muscle system a little bit higher than what a low load training would normally do, we are at an increased risk of being able to create a situation like rhabdo if we're not careful with integrating blood flow restriction appropriately. And so I spend time talking about it, and the research shows that if we can create an acclimation period, meaning a couple of sessions where we're doing very low intensity exercise with BFR, we can really reduce the risk of rhabdomyolysis, because the research suggests that BFR does, like other exercise, exhibit a repeated bout effect, meaning that if I get sore doing the same exercise once, I won't get sore or nearly as sore again, because our body has been given the time to adapt. So those are the two main safety issues, but ultimately we need to consider other comorbidities as well that may have vascular components. Things like diabetes, hypertension, obesity. These are all different what I would call or classify as precautions or yellow lights. So it's important when we're administering blood flow restriction to be aware of the potential cardiovascular, hemodynamic, or musculoskeletal complications that could arise from some of these comorbidities. But in general, what we found is we can screen these individuals out. And if we feel that we have an individual that would significantly benefit from the use of blood flow restriction, what we can do is reduce the pressure, which will reduce the absolute hemodynamic stress that the individual would experience. So it's less stress on the vasculature and less stress on the cardiovascular system as well. And then also, typically, blood flow restriction is applied what we call continuously, meaning that if I'm going to do a repetition set of 30 repetitions on the first set, followed by a 30-second rest, and then 3 sets of 15 repetitions after that, each with a 30-second rest in between, if I feel that an individual might benefit from blood flow restriction, what I would do is I would deflate during the rest period. And the newer research that's coming out now is looking at whether or not intermittent blood flow restriction, which is the deflation during the rest period, would that provide similar benefits to continuous BFR application. So that is a new area of BFR research that is ripe for the picking. But in general, what we want to do as clinicians is respect the body, right? And understand that blood flow restriction may be contraindicated in certain individuals, and there's nothing that really we should be able to, blood flow restriction is a tool in our toolbox, but we should have other tools that we can utilize for those patients that may be completely contraindicated to being able to do blood flow restriction exercise. So those typically, there is a risk stratification chart or list that we talk about that we can help classify patients that may be at higher risk, at moderate risk, or at very low risk for adverse events with blood flow restriction training. And that comes with, going through a training program,
Sure.
being able to understand and understand the reasons why people might be contraindicated or have precautions to BFR. That's really critical, and that's something that I really try to educate people on is because if we can understand why they might be at risk, then we can make a better clinical decision as to whether or not we want to utilize blood flow restriction in their plan of care.
So let's say good assessment and screening at the beginning, as from our part as clinician, shall avoid all those safety concerns on the patient where we apply a BFR.
Yes.
Okay, and just maybe a few examples, or if you can say something else regarding the application of BFR in those patients that have kind of polyfractured after motor vehicle collisions, or polytraumatized patients that can't cope with load, or maybe in complex cases after ACL reconstruction or knee arthroplastic, and these clinical cases.
So when I go and I talk about blood flow restriction, I really try to minimize hypotheticals. So what that means is that I want to utilize and teach people according to what we have available in the research base itself. And so while we have, for example, in fracture, we have plausible mechanistic ways in which the application of blood flow restriction can accelerate the recovery of healing of fractures. I don't necessarily spend a lot of time on that because we only have really 4 studies that show acute or chronic markers, and 1 study that was released last year a little bit early ahead of time, partially published by Lambert, that was in anterior cruciate ligament reconstruction, that showed that the application of BFR helped preserve proximal fibular head, as well as tibial distal femur and proximal tibial bone mineral density. So what we're finding, though, is that where bone is also another tissue that could, once you stop using it, you can lose it. But generally speaking, I like to frame the discussion around muscle mass. And the reason being is because if we can facilitate positive adaptations in muscle mass, that can help with our ability to regulate systemic inflammation. But also, in doing so, when you stimulate muscle mass growth, you also, with blood flow restriction, are going to be able to stimulate bone, are going to be able to stimulate vascular, are going to be able to stimulate all of the other positive adaptations that you're going to be able to get with blood flow restriction training. And we have a good literature base to support the use of blood flow restriction in optimizing muscle mass and strength. So I tend to focus the discussion on there. So the most well-researched populations with blood flow restriction are on anterior cruciate ligament reconstructions, as well as in osteoarthritis. And both of those situations are actually a little bit different in terms of the populations that are there. Now, right, if you think about the individual with knee osteoarthritis, that individual tends to be very load intolerant, but he or she is load intolerant due to the fact that the joint itself is inflamed and irritated and is not very congruent, right? Those tend to be older, relatively, if we're thinking about the gross picture, more deconditioned individuals versus the ACL reconstruction, which is post-surgical, tends to be more active, and those individuals tend to be able to utilize blood flow restriction as a bridge toward getting them from bed rest or post-surgical all the way back up to heavy lifting and return to sport. So it's nice that those 2 populations tend to be the most well-researched. And if I'm going to pick 2 populations by which I, in my clinical experience, have significantly benefited, it is those 2 populations. Because number one, with the osteoarthritis populations, the biggest complaint that you normally get as a clinician is, oh, if I need to strengthen, oh, my knee is going to hurt. It's going to hurt so much the next day, and then I'm not going to be able to move. Well, with blood flow restriction, because you're using such light weight, you actually don't get a lot of joint pain, and you can strengthen your quadriceps, which has been shown to help really predict functional debility and progression of osteoarthritis clinically. You can strengthen the quads, you can improve their cross-sectional area, and you can improve their self-perceived function and their actual function, similarly to high-intensity training. And that was a study that was published by Ferraz in 2018 that compared low load to low load with BFR to heavy load doing leg extensions and leg press exercise. And what they showed was similar benefits in blood flow restriction compared to high intensity training. But what we found, well, what they found and what I find clinically is exactly what was reflected in their results, which was that 25% of the individuals that were in the high intensity group withdrew because they had knee pain. And the only reported groups that reported a reduction in knee pain were the low load BFR and the low load without BFR groups. The difference, though, is the low load BFR groups perform similarly with their functional tests and their improving their muscle mass and strength. So really showing that when you can utilize blood flow restriction in the plan of care of individuals that have symptomatic knee osteoarthritis, you can make a change in their life. You really can change their life. And then there's the other population, which is anterior cruciate ligament reconstruction, which suffers from very long-term, both short and long-term quadriceps atrophy that happens very rapidly. Well, what we can utilize in our clinical practice with surgeon approval, mind you, because all the surgeons need to be aware of that blood flow restriction is utilized in their clinical practice, and that's something that I talk about in my workshops. But once you have surgeon approval, you can utilize blood flow restriction to accelerate their performance and recovery by stimulating the quadriceps to a greater degree during things that you're normally doing. So I spoke at the Kinesport conference in January about ACLs, and the topic really was BFR is better for results, but the main topic within that is BFR is not reinventing what we're currently doing in our ACL rehabilitation. It merely is complementing it. So what we're doing, so for example, early stage ACL rehabilitation, we're normally pairing Russian with our straight leg raises, right? Well, what we can do to try to overcome some of that arthrogenic muscle inhibition is to pair that with Russian and BFR. So now we're creating a cell swelling effect along with the muscle recruitment that we're getting both voluntarily and involuntarily with the stimulation, and we're doing the same exact thing as we would normally do in clinic. Similar examples persist throughout the entirety of the continuum of care of ACL rehabilitation. All we're doing is we're utilizing the unique effects of blood flow restriction to augment muscle mass and strength in temporarily load compromised ACL reconstruction patients. So I don't want people to think that we have to use BFR for everything, because that's not necessarily appropriate. But we can utilize BFR strategically to complement our plans of care in everything that has been shown in hundreds of studies beforehand. We're just augmenting some of the effects of our therapy, which coincidentally also can improve our ability to do other things, such as gait training and neuromuscular reeducation, because BFR has been shown to have a significant what we call hypoalgesic effect, meaning a pain relieving effect. And that has been shown in a lot of different studies in patellofemoral pain with Giles in 2017, In the Hughes papers, Luke did a couple of fantastic papers in the NHS system involving anterior cruciate ligament reconstruction, and showed that BFR had a superior hypoalgesic effect compared to heavy load training in the leg press. But also, most recently, in other studies like the osteoarthritis studies. And now Hughes and Patterson are going into determining what are some of the mechanisms that underlie the analgesic responses that we're getting with blood flow restriction. So it's not just about muscle mass. It's not just about strength. It can be about improving the quality of life, both from a functional perspective, which is what one of the systematic reviews by Clarkson last year showed, that BFR can improve our function, but also in terms of pain relief, in terms of potential augmenting bone healing, in terms of vascular responses. There was a recent hypothesis paper in Cells that by Vogel earlier this year that was fascinating, that basically hypothesized that some of the benefits that we observed with blood flow restriction and some of the adverse effects of peripheral arterial disease, that we can actually create some beneficial adaptations with individuals that have peripheral arterial disease, even though it appears that the use of restricting blood flow in individuals that are ischemic already have, it seems paradoxical. So what I'm trying to say is that BFR is an area ripe for research that isn't going anywhere. It's going to be in our clinical practice from now on. Our job as clinicians is to make sure that we are implementing it safely into practice.
Perfect. Thank you, Nick. Oh, I think that we can go on till next day talking about BFR and the research behind it, but really thank you, that had clarified a lot of key points regarding the application of BFR in the rehab field. And thank you for being our guest in this NOVATALK, and hope to see you soon in Italy with your workshop.
I hope so too, but we'll see.
This surreal situation, and thank you again. Bye-bye.
Thank you.
Thank you. Bye.